Good morning, everyone. It's my pleasure to be with you this morning. I was explaining to my wife this morning that USET covers the tribes from Maine down to Florida, across to Louisiana, an area that right now is having a lot of weather effects. And so I'm hoping that everyone is staying safe and dry, and that everyone's internet and cell connections will hold up as we talk a little bit about pediatric immunizations. So I'm going to describe for you a program that we've been kind of trying to launch now since May, and I'll go through the different components of that program, and I'll also talk about the rationale for what we want to do to address pediatric immunizations. So Harry, if you can go to the next slide, please.
For some reason, it's not advancing, which it did earlier just fine. So let me see if I can troubleshoot this. Sorry about the technical difficulties.
And we have another person who's joined. Is there a chat function that maybe people could chat in, like where they're from? There we go. Will it advance now?
No, and I'm not sure why, because it did it just fine before.
Dr. Brown, did you try to press on the sides? Like clicking on the sides?
Click on the sides. Let's see.
Yeah.
There we go.
There we go.
You. Thank you, Gabby.
Welcome.
I'm glad to have technically adept people.
All right, so so this slide shows us the 2-year-old measure that IHS collects every quarter. And by 2-year-old measure, I'm saying that all children who are 2 years of age should have had every dose of this particular series. Down at the bottom of the slide, it spells it out. So it's 4 doses of DTaP, 3 doses of polio, 1 dose of MMR, 3 doses of Hib, 3 doses of hepatitis B, 1 dose of varicella, and 4 doses of PCV or pneumococcal. And so sometimes we refer to that as the 4-3-1-3-3-1-4 series. And folks who are in the capacity as an immunization coordinator or are in the immunization field, they can rattle that off pretty quickly. They know what we're talking about. But I want to make sure people understand. All children 2 years of age should have received every single dose of this series of vaccines. And if they haven't received even one of those doses, if they're just missing 1 DTaP or 1 pneumococcal, then they're not considered to be fully immunized on this measure. And if you look at the left-hand side of the slide, this is going back to FY 2012, you see that IHS was running at just a little bit above 70%, between 70 and 75% of our 2-year-olds were fully immunized according to this measure. And the solid line at the top is the Healthy People 2020 target goal. It's also now the Healthy People 2030 target goal. And we haven't been at 80% nationally as an agency for quite a number of years. I think you have to go back to 2008 or earlier to where we were 80%. But over time, from 2012 to 2016, you see that we've kind of gradually dropped even below 70%. And then we began our drift down towards the 60% mark around 2017. And then the pandemic hit and we dropped below the 60% mark for the first time. And so that's when a lot of folks were beginning to look at this information and say, oh, we got to do something. I've actually been trying to do something for a long time, but have not been able to gain much traction. But I was fortunate enough to be a part of the IHS vaccine task force And on our task force calls, I brought this up, and so did a few other people. And so they kind of gave us a little bit of room to think about how we want to address this and what we should do about it. And that's what I'm going to be talking about most of today. And this is the rationales, because the coverage has been dropping for a long time, and it dropped even more because of the pandemic. Go to the next slide. So this is the following quarter, actually the same quarter where that ended. So this is looking at just the children who received 4 doses of the pneumococcal vaccine. And the pneumococcal vaccine, because it requires 4 doses to be complete, we often think of that as one of the rate limiting steps in having children fully immunized. We have a lot of kids in our system who are fully immunized, but they're missing either the 4th dose of pneumococcal or the 4th dose of DTaP. And this slide shows you the MMR coverage for the same quarter. Go back. And it's showing there we're at 77.6 nationally, but you see the variability across the areas. And try not to look too closely at mine, because mine often is one of the lowest areas. So what am I talking about anyway if my area isn't up to speed? But you see that some of the areas have traditionally been doing really well. Nashville is actually one of the areas across the country. Even if you go back to the last slide, you look at the pneumococcal rates, Nashville is among the highest of the areas across the country in terms of coverage with that measure, just looking at 4 doses of pneumococcal. Okay, we can go on 2 slides now. This isn't just an IHS issue, though. This is a national phenomenon. Next slide. And so this slide here shows you what happened when the pandemic struck. And it's looking at the number of visits to ambulatory practices. You can go back. And if you see the baseline there, so 0% change from baseline means that's how many visits there were on a weekly basis or a monthly basis. This is weekly. Prior to the beginning of the pandemic, so starting in February and going out. And then the pandemic was officially declared on the 13th in the United States as a national emergency. And you see right there, corresponding to that declaration, there's a huge drop in ambulatory visits, like 40% drop. And it got all the way down almost to 60%, and it stayed down for several weeks. Next slide. And along with that decrease in ambulatory care visits, we also saw a decrease in the numbers of vaccines that were ordered by providers who participate in the Vaccine for Children's program. This data is from an MMWR that was published in May of 2020. And it looks at it shows you how many orders every week were ordered for VFC orders in January and in February. And then again in March, you see where the national emergency is declared. And the following week or 2 afterwards, you see these declines in these 2 lines. The solid blue line is all doses of vaccine except for influenza that were ordered by VFC providers. And the dotted line is just the measles-containing vaccines. And so they each have a different axis. The non-influenza doses axis is on the left. And you see it went from, they were already ordering a little bit fewer doses. Maybe they had a stockpile saved up over the wintertime. But by the end of March and into April, there were about 3 million fewer doses cumulatively that had been ordered compared to normal. And that's for the all non-influenza doses. And then for measles-containing doses, it was down about 400,000. So providers recognize that people weren't coming in, and if people aren't coming in, they don't need to order more shots for them because there's no one to give them to. Next slide. And this data comes from a survey, a national survey of American Academy of Pediatricians and American Academy of Family Physicians that was conducted just prior to the availability of COVID vaccine. So from October to December of 2020. And what this shows here is asking these providers whether they actually suspended the routine non-influenza pediatric vaccinations in their practices during this time. And you see that about 20% of providers said yes, for the children 0 to 2, they did suspend routine immunizations. And then for the next older age group, 46 years, it was a higher number, almost 20% of both family physicians and pediatricians. And then for 11 to 18-year-olds, it's a little higher still, as fewer and fewer people were being seen, and they were not necessarily opening their doors to these 11 to 18-year-olds to get their HPV vaccines or update their MMRs or their meningococcal vaccines for a variety of reasons. We'll see on the next slide. So they asked them, well, why did you suspend these vaccinations? And what do you think were the barriers to providing these vaccines? And about 11% of pediatricians and family physicians both said that there were fewer in-person visits because patients and their parents were concerned about the risk of getting COVID-19 if they came into the office. And so that's one of the reasons for why fewer people were coming into ambulatory care services, was just they were afraid they might get COVID. And then there were some restrictions too, I think, related to access that, as we were dealing with the COVID pandemic, we had fewer staff available to deal with some of the things that we normally deal with in an ambulatory care setting, like patient sports visits. So there are fewer of those that happened. And that's a good time to vaccinate adolescents when they come in, because they're coming for a well visit, they're healthy, and you can get them their adolescent vaccines that they might be needing at those sports visits. And then other back to school related visits were also decreased that normally would have occurred, but because a lot of children were not attending school in person, but by way of virtual learning, families weren't coming in for those back to school doctor's visits that they normally might be doing. So these are some of the reasons why providers felt that they were not able to give as many vaccines, and why people weren't coming in for these different barriers. Next slide. And so the cumulative impact of that you can see on this slide. So that steep decline down to 60% or so of usual visits, and then it gradually came back up over the course of the pandemic. By the time we got, and you can see the little dips in there too, the upside down dips, where we had maybe different successive waves of the pandemic. By the end of last summer, people were starting to come back into the clinics. But it doesn't, you look at the size of the graph on the bottom of the graph on the left side, and the small increase on the right side, and it doesn't even begin to touch the amount of care that didn't happen. There's so many visits that didn't happen that we need a really big increase in visits and in vaccinations to make up for what we lost because of the pandemic. Next slide. So that's what we were thinking about when we reached out to the IHS administration with an idea, which was to have a campaign, not a media campaign, because we've done that before. Not IHS, but other agencies in HHS have done that before. And that didn't have much of an impact. There was actually a campaign launched at the end of last summer by HHS that had some impact, but not that much. But it was all a media campaign. It wasn't really very much about helping people to address the issues in their clinic and look at the way that they were working. And that's what we wanted to do. But we also recognize that we need to get some kind of name recognition and identification with IHS sites and with the staff. And so we reached out, Dr. Todt, our previous CMO, sent out an email to all IHS at our urging, asking folks to give us some ideas for what we could call this campaign, or this effort, or this initiative, whatever is going to be. help us put a name to it. And we ended up having over 200 responses. And out of those 200 responses, our core team selected this sort of slogan, which is safeguarding our future, protect their tomorrow, vaccinate today. And so that's what we've been using to kind of brand the materials that we've created. And this image on this slide is a word cloud. And the way we built this was just, we took all the free text ideas that people sent us by email and loaded them into the word cloud website. And they happen to have a pre-made figure, which was in the shape of a baby. So it was just perfect for what we wanted, because we don't have a graphic arts department to make designs and things like that. And we do work with contractors, but that always takes a long time. So we needed something quickly, and this is what we came up with. Next slide, please. So what we ended up creating was a short-term national improvement initiative designed to run from May through September. And it was led by a multidisciplinary team made up of members of the vaccine task force and other subject matter experts from across IHS. And we started with a kickoff webinar in May, and that was pretty well attended. We had over 200 attendees on that first webinar. And it was hosted on the IHS Telebehavioral Health Center of Excellence platform. And I put the link there. You do have to register with Telebehavioral Health to be able to view those recordings, but all of our webinars are recorded on there. So you can go there, create an account with them. You don't have to be an IHS employee to access it. You just have to make an account with them. We also engage with subject matter experts across IHS to help us write blog posts to focus attention on specific aspects of pediatric vaccinations. And those are readily accessed without any kind of an account on the IHS website. You just go to the main landing page and look for the IHS blog or newsroom, and you can find all of the recent blogs there. And then we've reached out to IHS leaders, so the area directors and the CMOs, clinic directors, nursing directors, pharmacists, to help promote this effort across IHS. Next slide, please. And as we started talking to these different experts, we thought about other things that we could add into this. And so the other offerings that we have are these Office of Information Technology town hall webinars. So the Office of Information Technology had started hosting webinars on Tuesdays and Thursdays early on in the pandemic in order to help get us ready for COVID vaccines. And so they did a lot of technical deep dives for RPMS and the new systems that were being developed to help us document and record and track COVID-19 vaccines. And so they already had a large following. People were in the habit of tuning in every Tuesday and Thursday. And as we started ramping up our program, they agreed to host deep dive technical webinars for us as well, to focus on those technical issues, the information platforms that will help us to address pediatric immunizations. We also started gathering information from CDC and other websites to create a pediatric immunization toolkit. And that's now off to the graphic designers to make it look nice and pretty. And we should have that released soon, but that does take a bit of time. And so a little bit longer than we hoped, but that's still in development. And then the final thing that we really put a lot of time into is developing a quality improvement collaborative that would be hosted by the IHS Office of Quality. And in the last few years, the Office of Quality has been contracting with a consulting group for something called Aimi, which stands for the Accelerated Innovations and Model for Improvement. In the past, IHS have been working with other consultants, and we've had a longstanding relationship with the Institute for Healthcare Improvement, which is actually where I met Dr. Brown. And, and we went through training with IHI on how to do quality improvement. And now IHS is working with this other group But they're using the same basic model, the model for improvement that we learned way back when. And the accelerated part of it is what's new in this effort, and it allows us to move a little bit faster than maybe we might have moved in the past with our quality improvement efforts. So in working with the IHS consultant, we've developed a charter to guide sites that are interested in improving their immunizations for pediatrics. And related to that charter is a whole family of measures that sites can adopt, and they can use those measures to guide and track their improvement efforts. So they can measure in real time what they're doing, and they can see the impacts. And the other thing that's happened with this relationship with the Aimi website and the consultants that work for that or that plan that is we've trained a whole nother army of people called healthcare improvement professionals. They're kind of like the improvement advisors that were in the first iterations of quality improvement in IHS. And these healthcare improvement professionals are located across IHS. There are about 50 of them trained up now. And so we're going to work with them to help mentor sites as they engage in this quality improvement collaborative. And we spent most of the summer actually working with the consultants, developing the measures, and then piloting those measures to make sure that we could actually collect that data and that it was actually useful. On August 9th, our CMO, Dr. Loretta Christensen, invited IHS sites to now officially sign up for the Quality Improvement Collaborative. So next slide. So since all this began, we've held now 4 of these webinars on the Telebehavioral Health Center of Excellence platform. The last one was on the 18th. We've had also 4 blog posts posted. We've had numerous OIT town hall recordings. I'd say we have about 20 of them so far. And combined all together, we have probably almost 2,000 views of webinars and recordings, either live or downloads. So we've actually had a pretty wide reach across IHS with this information. And that was really our main goal, was making sure that people have access to the tools and the training and how to use those tools so they can begin doing this improvement work. And this last step, this Pediatric Improvement Collaborative, is really one of the first, if not the first collaborative that has been launched in IHS using this new Aimi platform. And we worked with 2 pilot sites, Warm Springs in my area and then White River in the Phoenix area, to develop measures that we could track both pediatric and adolescent vaccination coverage weekly. And because we felt that if sites get into the habit of looking at their data every week and then posting it in some place where they can see it tracking, that they're going to be able to pay more attention to it, and they're going to see the impact of any changes they make. We also began measuring the total number of children that were vaccinated each week, the number of records that were updated. So if you have to update someone's contact information or update their immunizations, that type of thing, then we wanted to track that as well, because that's a big part of the work that we need to do to make sure we have accurate information in our systems. And then we also developed what we call balancing measures. So when you're trying to fix something, sometimes your attention gets diverted and something else goes haywire. And we didn't want that to happen. So one of our balancing measures was looking at weekly well child visits. Some pediatricians, and I know some sites have been concerned that if we focus so much on immunizations, parents will say, well, my child came in and got their immunizations. They don't need to see the doctor for a well child visit. We'll just see you in 3 months when they need the next set of immunizations or something. But that's not really true. We want kids to be seen by the pediatricians, by the family physicians and nurse practitioners to do those well child developmental assessments to make sure they're meeting their milestones and make sure that we can identify any problems early on before they become real problems. So we need those well child visits to happen. And we didn't want to mess that up by just focusing on immunizations. So we began documenting weekly how many well child visits happened every week. And if a site sees a decrease in that, then that might be an early warning for them that they need to go back and look at their messaging to the patients and their scheduling system and their access and figure out what they can do to make sure that that doesn't go down further. The other balancing measures are more standard, and those are patient and provider satisfaction. So simple 1 or 2 question surveys to patients and providers, asking them if they are receiving the care that they expected. And then also asking providers, are they feeling like they are able to provide the care that patients need? And negative responses in either of those domains also are early triggers that you need to look again at what you're doing and make sure you're not breaking something that wasn't broken before. Next slide. So this is a screenshot of this Aimi website. And you know, one of the issues that might make it a little bit less applicable for your area and my area, to be frank, is that right now the contract with IHS is really for the IHS sites to be able to log in and use this site directly. But they are working on their contract maybe for the upcoming fiscal year that might include an expansion. So we're hoping that we'll be able to include more tribal sites as well. But what happens when you log into this website, it has everything laid out from the model for improvement. So if you're not familiar with that, the model for improvement is based on 3 basic questions. First question is, what are we trying to accomplish? And that's what the charter tries to help you communicate to yourselves, to your stakeholders, to everyone involved. And so the charter really lays out, like, we're trying to redesign how we research our immunization coverage, how we contact and schedule patients to come in and get vaccinated, and how we deliver vaccines and address vaccination gaps, and really addressing those kids who are unimmunized or under-immunized. And so this is where we answer the question, what are we trying to accomplish? We're trying to make sure that we can vaccinate children who are under-immunized. Next slide.
Sorry, Tom, I seem to be having technical difficulties again.
Can you get down to the bottom of the slide?
Yeah, there it is. Okay,
There it is. Yeah.
got it.
So the next question in the model for improvement is, what changes can we make that will result in improvement? And this is best addressed or answered by the old faithful PDSA cycle, Plan, Do, Study, Act. And anyone who's been around in IHS for a while or has been involved with quality improvement in other organizations will recognize this. And there are other iterations of this or other ways to describe it. But when you're trying to make a change, one of the most powerful things you can do is make some predictions about what's going to happen. If I change this one component, what's going to happen? If I say, you know, our kids are coming in for immunizations when they come in to see the physician, but what if we had a nurse-only clinic or an immunizations-only dedicated clinic on the schedule where parents would come in, they could make an appointment ahead of time, even the same day, or even, you know, even in walk-in basis, and come in and get shots that they need when they need it. And that might be a faster way to do that. And it might be a way to increase accessibility to our vaccination services. Well, we can do a PDSA around designing that kind of a clinic. And we can predict what's going to happen, like we're going to have more kids immunized, or we're going to have all kinds of problems. You know, people aren't going to get seen, or we're not going to have people to staff other parts of the clinic. You know, there could be negative impacts. So whatever our prediction is, we need to put that into this PDSA. And then we try it out for a day or two and see what happens. And so that's the do part. And the study is we collect information about what happened, how many kids came in, how many vaccines were given. And then the A is the analysis. You know, we look at that and we make some decisions about what happened, and then we move forward. And so you can do multiple iterations of these PDSA cycles. And when it's time to act, it might be time to do another cycle of PDSA doing the same thing, but maybe a slight tweak or slight change here or there. And then you do that several times until you get to the point where it's like, this is running really well. We're ready to implement this. And so that's already built into the charter. And that's one of the beauties of the Aimi website is you click to a different part of the website and you come to these PDSAs that are already built for you. And if you click on that blue go to PDSA cycle box, it'll open up a nice color-coded way to step through and document your PDSA. And it really helps guide you, because one of the things that we found doing this over the years is that people like to cut corners, and the PDSA was one of those things where they would do it because they had to, but they weren't really doing it the way they needed to. And the most powerful thing about this is the prediction part, where you learn. Because you could think that you've got the best idea in the world, and then you do it, and it all falls apart. And what was your prediction? Well, your prediction was that it was going to work great, and it didn't. And so it's a good thing you found that out before you just made a broad sweeping change across the entire organization. And this is really one of the ways that we can be innovative, and we can stimulate innovation in our sites by doing this kind of work. So that's what changes can we make that result in improvement. And then the last question is on the next slide.
Well, unfortunately, my internet is acting up, but
Very good.
sorry.
That's okay.
There we go. All right.
So the last question is, how will we know that a change is an improvement? And so that's where we get into the measurement. Because we have our PDSA, and that might be looking at one small measure that we're going to be impacting. But then we also want to look overall in the system and see what can we measure that will tell us that we're going in the right direction. If we do several PDSAs, if we change several things in our system at the same time, how are we going to know that those changes are resulting in improvement? What's going to guide us? And that's where these measures come in. And I think the next slide I've blown up so it's easier to read for me and for you. Yeah. So the measures that we've put into this collaborative are the following. And these all come from the RPMS immunizations package. So they're things that are already measured by canned reports. So you don't need to be a super programming guru to get most of this data. So the first one is the percent of adolescents, those who are 13 years of age, who are up to date on a composite measure that includes 1 dose of Tdap, 1 dose of meningococcal ACWY, and they're fully vaccinated for HPV with either 2 or 3 doses. And so the immunizations package actually has that measure embedded into it. So all you have to do is run the immunizations package once a week and look at that number and post that number in the website and start tracking that. The other measure is looking at the percent of children who are 3 to 27 months old, which is another report in the immunizations package, who are up to date on all the measures. And I put 431, 3314, but it's actually even more than that. It also includes rotavirus and hepatitis A and a bunch of others. So we're really looking at the percent of children 3 to 27 months of age who are fully vaccinated. And you run that report and you get the number very quickly and you put that into the website. The next report is the total number of vaccines that were administered to children 17 years and younger each week. And that can be done either using iCare or using VGen. So that's a little bit harder to do. And if you're not an RPMS user, you're going to be like, what the heck is this? So iCare and VGen are 2 different ways that we have to query the IHS RPMS system at a clinical site to be able to gather information like how many kids did we vaccinate this week? How many patient visits did we have for diabetes? How many well child visits did we have, which happens to be the next measure that we have. So we're using VGen to generate that measure as well. There are some other ways that we can do it, but that seems to be the best way to do it. And then the stakeholder satisfaction piece comes from these simple 1 or 2 question survey that we give out to a sample of patients each week and also to providers each week. So those are the things that we're collecting. It's not a whole lot of burden for collecting these measures. It probably takes I would say 30 minutes a week to gather all this information and post it in the website. So that's not too much. The part that's going to take a lot is all the planning and the doing of the PDSAs and working with your team to try and figure out what else can we change to increase our access to pediatric vaccines and to increase the coverage of pediatric vaccines for our population. Next slide.
Sorry, it's those technical gremlins once again.
No, I have that sometimes in Zoom, particularly.
Yeah,
It doesn't, the arrow won't go where I want it to go.
it's also not bringing up the advancing. Let me see if I can.
Will the
Give me a
space bar
chance.
work or the down?
Let me try the space bar. Nope.
Or the left or right.
Yeah, they nothing that's supposed to work works. I've noticed that sometimes when people enter, it seems to okay, there we go. Now it's reset. There's the slide you want, I think. We seem to have lost Dr. Weiser.
It says that he's on, but it says that he's muted.
Okay, here I am.
Ah, you're back.
So my computer died. It gave me this blue screen of death and it's going to be restarting. It's 80% complete. So now I'm on the phone. Hope you can hear me okay.
We can hear you very well, thanks.
Okay. So what this slide shows now is that a couple of things that we've collected nationally since we began this effort. I'm not going to say that this is the impact of what we've been doing because it's too soon to tell. And plus, these are measures across the country in sites that haven't been doing maybe anything to improve or haven't been really focusing on this issue yet. But we've continued to measure this data every quarter. And as you saw before, when I showed you, it went down to 56.9 or 56.7. And then the next quarter, it's gone up by 1%. So we've had a slight increase there. That's on the 2-year-old coverage. And on the meningococcal coverage, we've seen a little bit more of an increase. So, and I think that was mostly because there was one area that had a huge decrease in their meningococcal immunization rate. And they bounced back very quickly over the summer and got those adolescents in for their meningococcal vaccines. So that's, I think, why there's a bigger increase there for meningococcal. Next slide. There we go. And this is one of the last ones. So, so I usually try to finish this with describing how folks who are interested in this topic can support our effort in IHS to improve immunizations, but also more importantly, how they can improve the immunizations at their own site. So one thing would be reaching out to clinical directors, nurses, healthcare improvement professionals in your area, and just encourage engagement with this collaborative improvement effort. And so if you are in a leadership role in the area, then that's something that you might be able to do. If you're at a clinical site, but you're not the clinic director, You might tap them on the shoulder and say, hey, how are we doing with immunizations? And what can we do to improve? And then encourage those who can to log in and follow our site, our project on the Aimi website. As I said before, that's primarily open only for the IHS sites, but we are working to be able to make things available for the tribal sites as well. And even if we're not able to open up the Aimi website and all those linked features, everything that's produced in that website, we can share with tribes. So the charter as a PDF we can share, and then you can edit that and make that your own if you want to tweak it a little bit. And then the data collection piece is all on a website, like an Excel web spreadsheet. So you can get a copy of that spreadsheet as well. The charting of the data in the Aimi website, they actually use something called control charts, which again, we learned about in our Improvement Advisor course years ago. And the healthcare improvement professionals are also learning about control charts. And the Aimi website automatically plots the data into control charts, which is just a special way of looking at data over time so that you can quickly identify when things change. And you can annotate that. You can put a little description on there about what you did that might precede a change. So you can demonstrate the impact of what you've been working on. There are alternatives to the Aimi website, including add-ons that you can buy for Excel spreadsheets that will help you do the same thing. So that might be a way to go. And then also the sample PDSAs would also be shared with any site that's interested in doing this. We also asked, especially for the RPMS sites, that they work with what we call clinical applications coordinators and the IT specialists to make sure that their RPMS package is fully installed, that the latest updates are installed, and that it's optimized so that they can do this work. Because if you don't have the current version immunizations package, the measures aren't going to be right. If you don't have iCare or VGen, or you don't have access to it, you're not going to be able to run the reports. And those are really important. And then finally, we have been talking about how we can reach out directly to tribes, to tribal organizations, and including the tribal epidemiology centers, because that's where I work, and those are the people that I usually in day-to-day work with. So they can work with those sites that don't use RPMS and enlist their support for monitoring their pediatric immunization coverage. I'll talk about that for just a little bit, because I think you guys are in a similar setting that we are in Portland. Most of we have 43 tribes, but only 6 of them are federal. And out of those 43 tribes, only a small handful are still even using RPMS. The vast majority of sites are using what we call commercial off-the-shelf EHRs, and they come in all different stripes and colors. And we don't have any ability to really support how to get data out of those systems. So often a facility will get an EHR, but they might buy a bare bones or stripped down version that is really good for billing and okay for documenting the clinical visit, but not very supportive for population health management, which is really, I think, one of the strongest parts of our PMS is the ability to query the system, to pull data out, and to know where you're going, whether it's monitoring immunization rates or diabetes rates or diabetic screening rates or anything like that. So we really need those abilities, and that's where we have a difficult time, a huge task ahead to help support tribes who want to do quality improvement but don't have the data tools at their fingertips. Some of this work also involves working with state health departments. For example, to develop the ability to exchange data between your EHR and the state immunization information system, or state immunization registry, as we often would call them. And there are tools in place that allow EHRs, both RPMS and non-RPMS, to exchange data 2 ways. So when you give a shot in your clinic, it automatically gets posted into the state system. And when someone who goes to your clinic gets a shot elsewhere, that information also rolls back to your system. And so that 2-way exchange is really critical for having a best idea about how well people are vaccinated and what vaccines they might need at any given visit. Currently, a lot of sites do a lot of manual work in that area. When a patient comes in, they look up their immunizations in the EHR, and then they log into the state system to look it up. The latest version of RPMS has the ability to query the state system at the same time without having to leave EHR or do a separate login. But those kinds of things are pretty advanced, and we want to make sure that sites have the ability to use those tools if they exist. And some of this two-way exchange may also require data sharing agreements to be executed between tribes and the state health departments to help with that. And I think my last slide is just a picture. So this is one of our mountain lakes in Oregon this summer, and we'll open it up for questions. Are folks able to unmute and ask questions or do it in the chat?
Yes, people should be able to unmute. Let me know if you can't. First of all, I want to say thanks for a really excellent presentation. And secondly, I want to apologize for some of the technical difficulties. Does anyone have any questions for Dr. Weiser? This is your chance to ask the expert. I did have, well, it's, yeah, sort of a question. So it sounds like it's not currently possible for federal sites to access the AIMI website or any of that material.
Right, for the non-federal sites, right. So what we'll do is we've received applications from non-federal sites, and when we get the application from them, then what we'll do is if they're on RPMS, we might actually be able to help to enroll them in using the Aimi website. That in yesterday's meeting with our team, it still wasn't clear at the end of that meeting whether that was going to be the case. So if you're a tribal site, but you're still using RPMS, we might actually still be able to support you using the Aimi website. And so there's an application process that if you're interested in this or you want to learn more, just reach out to me by email. And I should put my email in the slides, but we can share that maybe through the chat.
Yeah, are you able to do that, Dr. Weiser? Or?
Yes, I can do that.
Okay.
But I can't do it and talk at the same time because I'm just not that talented. But yeah, just reach out to me by email and I will send you the application or pre-enrollment form, which just asks a few sort of readiness questions like, are you on our RPMS? And do you know what your current immunization rate is and things like that? So it's not rocket science at all. And it'd probably take you about 10 minutes to fill out the form. And you send that back to us and then I'll bring that to the team and then we'll figure out what we do next, whether we can open the gates to Aimi for you or whether we would, reach out to the area health and care improvement professional to work with you directly. And then we share with you all of the tools and things that we've developed as separate files that we would email to you. The other thing that folks would want to consider is the IHI Open School. If you're really interested in quality improvement and you want to get started, there are a bunch of IHI Open School courses that you can enroll in. I think you can enroll in them through IHS for free. So that's a good idea. And then if there's any clinicians on the line and you have to do your maintenance of certification for board certification, this is right up your alley. This is made for you. This is perfect because if you engage in this kind of an improvement project, you document your effort, you can knock that requirement out of the ballpark very easily, and either by using the IHI Open School or the Aimi website, or just doing it on a spreadsheet on your own, or even hand tabulated data. You can just get a piece of paper and a pencil and keep track of your data that way. That's all you have to do to meet those maintenance of certification requirements. And so maybe that's a little carrot that we can dangle for the clinicians to take this on. But, we have, just in terms of the urgency, a lot of schools are coming back to in-person learning in the next weeks, if they haven't already. And we're in the midst of this Delta coronavirus surge. The last thing we need is a measles outbreak or a meningococcal outbreak from kids who are under vaccinated. So for so many reasons, and all the babies who were born during the pandemic, who may not have come in for those well-child visits, may not have come in for immunizations, those kids are not protected. So we have a huge amount of work to do. And as my colleague Scott Hamstra, who's also part of this, has said multiple times, we work usually Monday through Friday, but babies are born and have birthdays every day of the week. So every Monday, we're already 2 days behind our work, because those babies that happened over the weekend or that aged into a new age cohort and are now due for shots that they weren't due for on Friday, now Monday they're due. And we've got 2 days worth of those babies. So every Monday we're already behind. Well, the pandemic was like, a year and a half of weekends. So that's how far behind I think we are, and how much of a huge lift this is. So I would caution folks, don't underestimate just how much work this is. And if you've been keeping up, then congratulations to you. I want to hear from you, because I want to hear how you did it, so I can share that with other people and maybe invite you to share that on one of our webinars, because we are collecting all those best practices. And you can see those on the recorded webinars on the Telebehavioral Health Center of Excellence site. And that's all I've got.
All right. Well, thank you again, Dr. Weiser, for that really excellent presentation. And sort of as a token of our appreciation for your cooperation with USET, your dedication to public health and well-being of Indian people everywhere, we'll be sending you a small gift in the mail in the next few days.